everyone. We are live with our third monthly Facebook live stream. I am so excited. I am here in Jersey at the Scoliosis Specialty Center with Chintan and Marissa. We're going to get everyone introduced and talk about it. I'm going to delay a little bit while people are starting to join. For anybody who this is your first time listening in on one of our live streams, please go back. We have two other live streams that you guys can watch. The first one is with Dr. Vitale from Columbia University and Columbia Medical, and the second one that we just did in September was with Allison Gerber, the author of Braced, one of our favorite books. And now, as I promised you guys, we are going to be talking about Schroth. So, I know everyone's expecting 7 o'clock, so I'm just going to delay for a bit while I'm pulling up the video of us on the other thing so I can follow everyone's comments. Let's do this. Great. All right. Okay. People are starting to come in, trickling in. Awesome. We got a shout out from Melissa to Chintan already.
Hi, Melissa. Miss you too.
All right. So let's get started with just introducing each of you guys. Who wants to start?
Go right ahead.
I'm Chintan. Chintan Pancholi-Parekh, long name, short in stature, but having fun with you. I'm a physical therapist by profession, so first, shout out to our profession, Happy PT Month. So it's a great time to do this.
I didn't plan
live
that.
stream. Yeah, fantastic.
I'm so excited.
Best things happen by accident. I have been a physical therapist for over 15 years. Primarily started out in pediatrics, and Marissa tells a wonderful story on how we got into Shroff. So I'm going to leave the fantastic story for Marissa.
Oh, you want to hear
yes, she does the best story. She does the best story.
That sounds good.
But basically, my passion is really combining Schroth and pediatrics. Slowly working in like different areas, not just AIS, but some of the neuro-based. So that's kind of like where I'm leading. I'm also a lab assistant level 2 for Shroff Barcelona Institute, which is the primary teaching body.
Mm-hmm. And we'll get into all defining what each of those things are that you just said.
Yes, and we both are members of SRS and SOSORT as well as APTA.
Awesome.
Yeah, that's
whatever
quite
she
the
didn't
list.
cover of you, if you want to introduce yourself.
Hi, good evening. I'm Marissa Muccio. I am one of the owners. Chintan and I, we both own Scoliosis Specialty Center. But the story of Schroth and scoliosis is fairly new to our practice. So I've been a physical therapist for almost 20 years now. And our practice still is, but was before Schroth came to the United States, a pediatric neurodevelopment practice. And so we deal with children with neurological disabilities, school contracts, early intervention, etc. We're also clinical instructors for Rutgers Doctoral Physical Therapy Program. Shout out to Rutgers. And just kind of going around, minding our own business with our practice, enjoying our profession and our growth. And the story of Schroth is that one day I got a phone call from a local spine surgeon that I'd worked with for almost a decade. And the irony does not escape me because the phone call went as such. He said, Marissa, I know you don't do ortho, but would you do me a favor and take a look at this exercise program from Europe for scoliosis? And me being what I thought was a very good physical therapist responded with, there's no such thing as exercise for scoliosis. We teach this all the time. He said, yes, I know there's no such thing as exercise for scoliosis. And that's because in the United States, actually North America, in the 1980s, there was actually some fairly well done comprehensive research on general physical therapy and AIS. And it had shown that general physical therapy does not impact the progression risk. So we kind of had known that historically, and so within the curriculum of general physical therapy, there really wasn't a lot about scoliosis. So he said, no, please do me a favor, because I had this family that flew to Barcelona, Spain, and did this intensive exercise program. She came back with significant changes in her curves, actually some reductions for that particular patient. And he said, there's a textbook, there's an international medical society, and there's a little bit of research. This, of course, was 8 years ago, 9 years ago?
Wow.
8, yeah. And so he sent me all the information. And by the time I was done reading it, it was immediately obvious. I call it not one light bulb moment, but like 8. They all
Christmas
went
tree
off.
of lights.
It was. And I was just like, how do we not know this? How is it not a part of our curriculum? And how did something that started in the 1920s take this long to traverse to the United States? And so that began our journey. And now the irony is that I happen to have been one of the early first classes in the United States for Shroth. Mm-hmm. By the time I was done reading Krista Leonard-Schroth's textbook and understanding that it's really motor learning and motor training. And this is what we as pediatric neurodevelopment therapists do really well, is teach movement. Mm-hmm. So that's how we ended up.
That's awesome. Very cool.
Yeah.
So you were a doubter at first.
It wasn't a doubter. I was really quoting the current literature that we were taught in our curriculums from all the way back to the 1980s. And it wasn't until we really began to understand the difference between general physical therapy, especially in North America, and what's in the curriculums, and scoliosis specific exercise, and how they are not the same. And once we were able to really grasp that difference, and understand the mechanics and the anatomy and the physiology and the underlying aspects of evaluating a spinal scoliosis, we never looked back.
Yeah.
And now we have 4 offices.
Well, that led perfectly into my next question. So we are here in northern New Jersey in I never say it right. Totowa.
Got it.
My GPS says Totowa.
That's I like that better. We're not in Kansas anymore.
Yeah,
Totowa.
and we're in Totowa.
But you have multiple offices that you can tell us about.
We have an office in Totowa, New Jersey, which is kind of North Jersey. We have an office in South Jersey near Princeton, Lawrenceville. We have an office in Manhattan, and we're proud to open up our newest office in the Charleston area of South Carolina.
Awesome.
Very exciting.
That is opened?
Beach. Yes, it opens in November.
Opens in November. Yes. Very exciting.
We are very excited.
So I hope that people in North Carolina will be able to find you.
Hope so.
Yeah. South Carolina. I'm sorry.
That's okay.
South Carolina. That's okay. Shout out to my Dellas from Citadel.
Yay. All right. So let's get started. Very basic question. What is Shroth?
Shroth, the best definition I usually explain to my patient, it's a cognitive sensory motor training. So just like scoliosis is a 3-dimensional diagnosis, and this exercise program is 3-dimensional exercise program. So that's the simplest version, I think I could say.
Right.
But it involves cognitive. So you have to be able to follow certain directions. Sensory, so the feeling of how to change things, and we use our hands, and we might use the mirror, verbal cues, manual cues, all those kinds of things, and motor training, obviously, which is the actual exercise part and moving the sections of our body differently.
Right.
And the meat and potatoes, I say, is you actually use part of your rib cage, so there is a breathing component, but it's all part of the training process.
And when you say it's a 3D look, explain what that third dimension is. Like, what does that mean versus 2D? So you're saying like a 3D, it's the rotation, not just the
exactly.
curve.
So there's usually before, and Marissa, please jump right in. When you talk about scoliosis, the first thing people talk about is the Cobb angle. The Cobb angle is the idea of where the curve, the spine is turning, and as you see on an X-ray. I'm looking at my light box. So it's how it's turning. So it's just on this like a piece of paper, basically, right? But what is actually happening to the spine? There is not just a side bend, there is a rotation. And if you look and go detail into the pathomechanism, this is how we teach our physical therapists, is if there's an actual turning and then translating sometimes forward into the trunk. So anything else you want to add to that?
No, so we kind of tell some of our younger kids, when you think about scoliosis, as you had mentioned, the Cobb angle is really that one plane. It talks about how the spine is moving to the left or the right, but really in space it moves in all 3 dimensions. And so we kind of tell some of our younger kids, think about like a twisty pasta or a roller coaster. You know, it has some movement forward and side, and it's got some rotation. And so for Shroff, it begins with a very detailed physical therapy evaluation, and this is key because Shroff is not something that can be picked up on social media, or you can't look in a book and just start
answering all my
copying.
questions already.
So with this evaluation, there's a number of tests and measures, and we take tests and measures both clinically and off of the x-rays, so that we can determine not only the individual location of the curves, but the individual 3-dimensionality of that person's curve. We then teach them that corrective movement. So there's a thought process to learning, there's a sense of feeling, as Chintan said, from a proprioception, and then there's the movement pattern that you're learning. So think of that twisty pasta again, you're learning how to elongate it, align it, and then derotate it. You learn that movement, and once you learn that movement, you begin to execute it on your back, on your side, on your stomach, and in some fun other hanging positions. But as you can see, when you're learning that, you're actually taking your body and turning it 3-dimensionally in space. So you challenge that movement, that corrective pattern, you challenge it in all 3 dimensions in space.
Awesome.
And then, once that's taught, we start to move it into some daily habits. How you're sitting, how you're standing, how you're walking. For our high-level athletes, we'll break down a sport mechanic and see how we might be able to integrate some of the corrective patterns into that. Whatever works to individualize it for that person. So it becomes a new brain movement pattern for them.
This becomes their new normal.
Right.
That's cool. So let's say I'm coming in for my very first Shroff appointment. What am I expecting? Like, what should I expect for my very first Shroff appointment with you guys?
With us?
Well, with anybody.
Yeah, I mean, but it is, first of all, that is a very good point you brought up, actually. It might be different in different practices,
right?
Okay, so we do a very thorough exam, like Marissa said. The first day, we really do evaluate you clinically. So if you've ever had PT for like your legs or your arms or shoulders or whatever, you know, you'll go and get some strength measurements and range of motion measurements. So we are versed in doing the typical orthopedic measurements. So we do that as part of it because the spine does not just affect the trunk, it affects all parts, you know, because arms are attached to your trunk and your legs are attached to your trunk. So we do evaluate the full body, but there are very specific scoliosis specific measurements that we do that will help us evaluate all of the areas that it has impacted you individually. Some people have really been impacted from this side because of the scoliosis, sagittally. So that would mean how you look in your sagittal profile. Or some people
and say sagittal, what does that mean again?
How you look like, what your spine looks like from the side. So everybody in a typical spine is, when you look from the back, it's supposed to be straight. When somebody has scoliosis, she has this beautiful shirt that can actually say there's a curve in your spine. So that is a kind of like a frontal plane view of what is happening to the spine. When you say sagittal, you are looking at your spine from this side. Everybody has a cervical lordosis, thoracic kyphosis, and a lumbar lordosis. Kind of like your bump and sway. Everybody's supposed to have your bump and sway.
Right.
But some people have very large, some people have very small, and there is an acceptable range that we can have. However, because of the scoliosis, sometimes there is imbalance. What is happening in the thoracic versus lumbar, and we as physical therapists evaluate that. We also evaluate the rotational component, evaluate what's happening to the pelvis, what's happening to the head and neck position. Evaluation is also a fantastic place that we start our teaching. We start teaching you exactly what is happening to your body. So I feel like the biggest thing that I impart to my patients on evaluation is the education of what is happening and what kind of things that they should expect from me specifically to address their curve.
Right. That's amazing. That's so important because I think that there's a limited amount that we're told. So like I go in and, when I was 11 years old, I got told I have scoliosis. That means your spine looks like an S. And they simplify it to us, which is totally understandable. It's the first time you're even hearing the word scoliosis. But you kind of need to know, like, what does that really mean? And it starts to really, like, help you understand that is why my shoulders are uneven. That is why when I'm wearing a skirt, the hem looks a little off. And that is why, like, I'm more flexible. I can do a split on my left leg. I can't do a split on my right leg. And it helps to understand that much more for these girls who are just trying to figure out why they're not normal.
Right. And we want to identify that, each person's normal is different to begin with.
Exactly.
Okay? And we want to get you to as neutral as possible. And address the patient's goal because we all have different things that we want to get out of it.
Right.
You may care about the shoulders. I have another person that is an athlete and say, listen, I just want to be better at this. And how can Shroth help me with that?
Wow. That's really cool.
So
I definitely want to get more into like Shroth as an athlete, but I think we'll get into that like a little bit deeper.
Right. Shroth actually has value and application across a very wide span of scoliosis. We've been fortunate to work with some of the leading spine physicians across the United States, but especially here in the Northeast geography, including Dr. Michael Vitale, who you had on previously. And we've begun to apply it to younger patients, early onset, juvenile onset, of course, AIS. But, our kids with scoliosis grow up and they become adults with scoliosis. So we have modifications of Shroth that are applicable for pre-fusion, post-fusion. We've been fortunate enough, again, to even work with some of the newer surgical interventions called vertebral body tethering. We've had the fortune of working with Shroth before the tethering to facilitate and see what kind of flexibility and changes a spine can result in. And that facilitated the qualifications for that particular patient. And so we did one of the early case studies on the combination of Shroth and VBT. And so it has applications across a very, very wide range of patients. And so it's very important, as Chintan said, in that early stage of education to begin to adapt it to not only the patient if they're young, and navigate with the parents as well. Because for most of our girls, and boys, but for most, this is a journey. This is going to traverse a number of years, and perhaps depending upon what they're left with when their bones are finished growing, we might have education and recommendations for even longer term for them.
Right, and that's so important. I feel like because like you wear your brace for 2.5 years, and if it's effective, you get out of your brace, but then, what are you doing after that? Like, people are still monitoring you. You have to it's like you need these tools for your future.
Right.
And
Correct.
I feel like that's what Schroth is able to provide.
Yes.
Which is really cool. So let's get into some of the questions. This one was sent in earlier today. I know we have a lot of people who are in different time zones, so we try to kind of make sure that we're available to everyone. I know people are going to tune into this later. So we got a question. My daughter gets her brace in 2 weeks. She's an appointment with a physio who specializes in Shroff. How will this help the brace? So just want to make sure that it's, you know, it's not just the brace and it's not just Shroff. So how is it complementary to each other?
So I would say that there's a couple of things, because there are a number of different braces that are out there, and a good brace is a good brace. So a good brace typically has a good in-brace correction, and then if it's an all-day wearing one and not one of the specialized ones that overcorrect at nighttime that you can't stand up in. So, but for your typical full-time rigid brace, you know, we want to take a look at what the brace is actually doing to that person while they're in it. Is there some unusual postural compensation that's coming on from the brace? Schroth exercise plays an important role in that it is the active part of the three-dimensional correction. The brace is the passive part, and very often we can use the brace and where they feel the pressure to help actually teach them where their prominences are, and that's where you're going to move actively. Now, if it happens to be a Rigaud-Chenot type brace, well, for us, we're a little biased. Not a little, a lot. We really like the Rigaud-Chenot type braces for a number of reasons. One, they're, first and foremost, they open in the front. So doesn't that just make gym a whole lot easier? But they're typically a little bit lighter, and they actually don't contact you in totality the way some of the Boston TLSOs do. They're very asymmetrical and three-dimensional, and its goal is really to de-rotate as well. When our patients come to us with a Rigaud-Chenot brace, we're actually able to use the brace as a biofeedback. So we can teach them some unwinding and some derotational breathing while they're in their brace. There's actually a couple of exercise strategies while they're in their brace. So throughout the day, they can take a moment either at a lunch break or recess or afterwards at night, and they can actually learn and use their brace to feel where they need to correct and go.
That's great.
So the brace can actually become a tool. But for all braces, that's the passive process, and Shroff is the active process.
So that gets into one of my favorite things about when I'm talking about Schroth is I don't just love it because of the effect of it physically. I love it because it has this emotional effect on girls where we are given a brace and it's a passive thing, and we're told, here, wear this thing, hope for the best. And you sit there and you go, hoping. And Schroff puts power back in our hands. And it allows us to be able to actually do something about our situation.
Absolutely. Nested within the actual textbook itself, Crystal Leonard Schroff had identified and taken photographs of some of her patients from the 1930s who showed up at their clinic. Obviously, this preceded x-rays, this preceded bracing and surgery, you know, and their affect, you can see how this had weighed on them as individuals. And when they were finished with Schroff, you can see the sequence in their photographs where they became so much more not just opened and elongated in their spines, but in their emotional aspects.
Wow.
They felt empowered. They were making eye contact. We find so often, especially for some of our young teenagers, this can be another avenue of social emotional coping.
Wow.
And there's tons of literature, and just exercise in general is often good for neurotransmitters. It increases mood levels, and you just feel better. when you exercise.
Right.
So in our situations, to take a journey this long and give them a tool that can help empower them, but also the education so that they feel like this isn't going to define me and I can take care of this, no matter where the journey goes.
That's awesome. That's a really cool thing about Shroth, I think. Another question, we get this question a lot. I know that Melissa just posted on here. We kind of got it previously. And in general, it's how do girls stay motivated and to keep doing their exercises? So have you heard any things that, you know, those who are especially motivated, or like tips and tricks that you've heard from your patients?
Exercise in general, it's tough to stay motivated, right? Even me, like, listen, I have to get up and go to the gym. It's much harder. Do you agree?
Yeah.
It's harder. So,
you got cold and dark.
Support is the number one thing.
Absolutely.
I think, and it's so nice. I mean, most of the people that come to us, it's the family support, the friends, the Curvy Girls. It really is probably one of the number one thing that helps keep people. Me personally, I like going to group classes because I have other people who are in the same kind of headspace as me, because they're there to do a certain exercise. So I feel in our practice, I think expanding to the group classes allows them that social support and keeping up with the exercises. But really, when you go to Shroth, you can come up with some strategies that work the best for you, because each individual person is different.
Right.
So.
Right. And again, keeping in mind the age becomes really important. You know, parents ask frequently, you know, our younger ones, they sometimes have reward systems in place for them that work for that individual child. As you become an older teenager and you're kind of responsible for yourself, you know, you kind of have to be creative. We've had some of our kids make videos with each other. They edit them, they add music to them. They can stream together and find a friend that they're going to do it together at that time. And the wonder of modern technology is that your friend does not have to be in the same school district. You can have that Curvy Girl
or the same time zone.
Right, you know, from Australia. Well, perhaps maybe the time frames. It's really an amazing opportunity now to make friendships and encourage each other and come up with fun projects and fun motivators, logs, and competition is always on 50 per.
Yes.
We have an award for, there's a particular exercise called 50 per, which by the way is ridiculously hard to get to 50. And we've had, I think, 3 people over the course of all these years who's actually done all the way up to 50. Oh, wow. So, you know, a little competition goes a long way for some of our athletes, you know. And every now and then, you know, if they could beat their therapist, they think that's the best.
I love that.
Yeah.
Awesome.
Yeah.
Kind of what you were just saying about how, you know, you can do a lot of people together, or you can put your videos up online and watch it, leads me to my next question of, why can we not learn Shroff from a YouTube video?
Oh, that's our biggest pet peeve.
Right.
You take this one because I get all sorts of...
You know, it's just like what we said earlier. It is so individualized to your curve, okay? This is, again, it's a training program, so it's not as simple, hey, I'm going to make my biceps stronger, so I'm going to just do this exercise right here. It is not that. It is... You are moving a section of your body here, a section of your body here. This part is, the front part is doing one thing, the back part is doing another thing. And to train all of them together, you really need experts that can say, okay, first, what is exactly happening to your body, right? Because you may not even realize how your body is, and that's where our education during the eval will start. Right. And then we will step-by-step train you, because there is a method to our madness. There is a step-by-step procedure that we take you from. So it's not like I can just start working, I'm just going to work on my shoulders right now. It's not about, it's putting the whole piece together.
Right. And one of the key things that we always tell our parents and our patients, a healthy brain is actually going to follow a curve. It's going to adapt. And actually this adaptation is even better and faster and stronger in our athletes. So they're not often even aware of the compensations that have been created by a very healthy dynamic brain as the spine began to shift. That shift in the spine is a slow shift over time. So the brain adjusts and accommodates. It's one of the reasons why when we first evaluate and we take a picture in front of a grid and we say, you know, stand as tall and centered as you know how, they're like,
Yeah.
and they feel centered. So this is the healthy brain that has adapted and adjusted. And so you won't necessarily know that you're moving correctly.
Right.
One of my favorite randomized controlled trials for Schroth is actually Kuru, K-U-R-U et al. Out of Turkey. And why I love his study and that team's study so much is that they not only had a control group, but they had one group that actually got their Schroth exercises from just a handout and a home exercise program. And then their other Schroth experiment group was the skilled physical therapy training and intervention, and there were clear differences. The control group that got their exercises like a handout and kind of did them on their own, their outcomes were actually closer to the control group that didn't get anything.
Wow.
So it really shows, and certainly clinically, we say it all the time, you need the skilled physical therapy during this initial training process. The whole goal of Schroth is a training process that you then own and take yourself.
Right. Right. So our next question is from Annika, and she wants to know, does Schroth permanently correct the scoliosis curves? And I know that's got to be tough to, so it's not a permanent thing, we know, but it's a, you know, it.
So
Yeah.
there are a lot of questions that we still don't have answered in the research. When you're talking about Schroth, right now, the randomized controlled trials that we've seen, for example, one of the most recent ones, not a randomized controlled study, but a very good prospective one that was published out of Hong Kong, showed a small group that actually showed reduction in the curve that was greater than the X-ray error. The largest portion of the exercise group saw halted progression. And then another small cohort continued to progress. So there's a lot of conversation about, does Schroth reduce a curve? Does Schroth halt a curve? And the reality is, until we are clear about predictors, there are so many factors in Schroth. How good is your teacher? How well did you learn? So the personality type of the individual teenager or child, that plays a key role. Compliance is huge. We have some, and your dear friend Rachel, hi Rachel, is like the shining example. I mean, come on. She's taken Schroth and turned it into like an Olympic sport. And that girl has like, you know, by power and thought has like cranked down her curve into some amazing reductions.
Yes.
But she's very focused, she's very compliant, right? So that plays such a huge role. So until we have really clear predictors and understanding, it's just not appropriate for us to say to parents, we expect correction, or we expect reduction that is greater than the X-ray error. Right. What we can say based on the current literature is that when you are compliant and you have learned this well, it will help to halt the progression of your curve.
Right.
And then for the adult population, it gives them, we're in the middle of, that's a newer area of research. We don't even have as much research in the adult population as we do in the AIS population. So
that's great. That's a question evolving. That we have that is for older people can be doing Schroth.
Absolutely.
Everyone's still learning about it, but
our growing population is the adult, because why does a adult walk into our office 9 out of 10 times? It's because they either have pain or they have a significant change in their alignment that they have not seen before. and or functional changes.
Right.
Like they were able to do certain things, and now I'm like, oh, I can't really do that anymore. And what Schroth does is it takes the three-dimensional principles and applies it and modifies it a little bit for the adults. There are certain things that we don't do with adults that we do with youngsters. And I just want to throw in, there is a different level of training. So if you were certified by a Barcelona group, there is a level 1 training and a level 2 training. So the level 1 is for the AIS, and the level 2 is more for adults and other more complex, such as the JIS and post-fusions and things like that. But with that population, we are a little bit more focused on pain management, functional, and really those are the main goals, you know, and the alignment. So those are the main goals. It's not to the halting or, you know, reduction or any of those components.
Right.
Those are good questions.
Yeah, we got some really good questions. So once you stop growing, so for someone who starts Schroth, you know, when they're juvenile or when they're a teenager, early teenager, once they stop growing, does the Schroth exercises change? And then as you grow older and older with the Schroth, does the frequency that you need to be doing Schroth, or the exercise you're doing, does that change?
So one of the things that our clinic does is, and we've just come back from a geographical meeting with physicians and orthotists and other Schroth therapists talking about trying to gain a consensus of what we think about Schroth as a treatment plan across the lifespan. So obviously right now we have some very powerful literature that during the active phases of AIS, it helps to halt the progression. So we talk to our patients and our families about it's kind of like a numbers game. When you're done with your bones growing, what are you left with? You know, long-term research in scoliosis is kind of well established, and it shows that if your curve for the most part is 30 degrees or under, there's really not a lot of statistical difference between you and someone with a straight spine. So we have to be ethical and judicious in this treatment approach. And as young adults going into college or older adults, what curve you have when your bones are finished growing kind of leads the education and the recommendations for the future. Not just the size of the curve, but also the location. And Chintan can speak to this too, right? Thoracolumbar and lumbar curves, we're a little bit more on top of those, even for perhaps some of the smaller sizes, like in the 30s. The thoracolumbar section and the lumbar spine is really the workhorse of the biomechanics of the human body. And so our fastest growing population, as you mentioned, which is older women who have just spent decades not monitoring or following, you know, what they thought was curves, you know, 30, 40, 50 years ago when you got out of your brace, it was bye, have a nice life. Nobody really explained a whole lot to that particular generation. And so some of them are very shocked and surprised to have seen some of their curves progressed biomechanically. It's not the condition once your bones have done growing, but depending upon the size and the location, you can have some biomechanical changes over decades. So it becomes important to kind of understand what you're kind of left with and where. And again, this is the role we feel like we are giving our patients at a younger age, a body of knowledge and a toolkit to care for their spines long term, so that they kind of know what to do and they're not hopefully surprised 20 or 30 years down the road. So for larger curves, to answer the question a little bit more, for larger curves, we kind of recommend taking a few of those strategies and trying to integrate it into a regular healthy lifestyle approach. And then to think smart. Okay, so I want to go mountain biking. You know, I'm in my 20s and I got a group of friends and we're going to mountain bike for, 6 hours. Well, that's not great for anybody's spine necessarily. So, maybe you do your back exercises the day before and the day after. So you're really just kind of this is your spine. I always say, when I was a teenager, I blew out my knee dancing. So I always do 2 exercises for it. And it's helped take care of it so it doesn't bother me now that 50 is smacking me. So, you know, you just kind of make smart decisions about how you're going to integrate it. But for smaller curves, no, go enjoy your life. There's really, in my opinion, and in what current research says and what we've seen clinically, the smaller curves, no.
Yeah. We focus more on, hey, what do you like to do?
Right.
So if a college-bound student comes and say, really, I prefer the yoga, or I prefer the Pilates, or I prefer going to the gym, I will give them education, again, like what Marissa said, like if there is, you just balance it out.
Right.
What is your alignment? Like if your pelvis has a tendency to do a certain thing, how do you keep it in neutral when you're doing a particular yoga pose?
Right.
You know, so those are the kind of education pieces. You know, that education, I feel like it's so superior, like it has to be really drilled into all of our patients, because if you really understand what is happening to your body, then you're not memorizing this stuff. It becomes part of who you are and how you live and move.
So it's the fact that we have this rotation, we have this tilted pelvis or something like that, and that is our normal. And until we're told that is what you are actually off balance, if you do this when you do something as simple as walking, when you do something as simple as unloading the dishwasher, you're bending down, instead of doing this, do this. You know, that slight like shoulder adjustment, right? So it's not these major exercises all the time. It's this little tweak, so that way you're able to recognize and be more in tune with your body.
The big cognitive part of it.
Right. About how someone with a straight spine would actually be doing this. And that then, if my understanding is, reteaches and trains your body.
In physical therapy, it's called neuromuscular re-education. And so
neuromuscular re-education.
It's kind of it's like you're creating a different map in your brain.
Right.
That's exactly. We're just creating detours of what your brain pattern wants to use, and now what we're forcing it to use a different pathway.
Right. So when they say you never forget how to ride a bike, you never forget how to walk with your pelvis in the proper tilt.
Yes.
There you go.
Awesome. Let's talk about right before a lot of girls will find out about Schroth right before surgery. So they're saying, I've been told I have to go in for surgery. Should I even bother doing Schroth? What would the benefit of getting Schroth in before having surgery be?
I think this is a newer area of application. There's not a lot of research that's talking about scoliosis-specific exercise as a pre-operative treatment. Of course, there is a very wide range of general orthopedic physical therapy that is applied before other types of orthopedic surgeries like knee replacements and hip replacements, etc., for the purpose of pre-operative strengthening. That hasn't really been evaluated in this particular area. We've been fortunate, again, working with some of the leading spine physicians in this area to, as a team, some families, you have to take into consideration, it's like 3 circles, that Venn diagram that kind of comes together. You've got the research in one, you've got the clinical experience in the other, and then you've got what really is important to the patient and the family. And so that's where working together as a team becomes so critical. So for some, we really know this teenager absolutely, definitively is done with the conservative treatments, and they just want nothing more to do this. They want the surgery, and they really want this to be kind of ended and do that. Then great. Then we have some who really want to try. And that's where the physician and our teams and the family can get together and create an individualized plan. Can we buy 6 months and see there are some curves, if they're too large, you don't want to wait too long. Right. Moving into larger and larger ones can actually increase the complexity of the surgical correction. Right. So, but for some, if you're talking about some of the gray zones, the upper 40s and lower 50s, and a family wants to try and see how that spine and that curve and responds with a compliant, we have that conversation again as a whole team, and we go from there. So even for pre-operative, as a team plan, we talk about whether it's appropriate for that individual patient and family.
That's great.
But for us clinically, as the geeks, I kind of sort of think it's a really, really interesting. I'd love to sit down with a whole bunch of surgeons and find out, okay, so if we really gave them awesome Schroth training and they were compliant and really good at it, are there actual differences in their surgical correction, their mobility, the flexibility of the spine, the correction? I think that's all really kind of interesting questions.
Yeah, definitely.
The recovery process. And
yes.
We talk about pre-op PT in my mom got a total knee replacement done. She had to go to therapy beforehand and after. So it's, Marissa always says, it was surgically removed from scoliosis care, pre-op PT. Yeah. So, what does, it's a great question. Obviously there was limited research, but it really, it would behoove me to say, well, I think we could have at least basic strengthening.
Right.
And it's so specific to that person's spine that Schroth does. So, it would be interesting to see.
Definitely. So let's go to the next phase, which is after surgery. And I know I was shocked to find out that you could do Schroff after surgery. So what does that look like, Schroff, for a post-fusion patient?
Again, what I said before, just like with adults, we do modify. There are certain things with, a person that is fused, we're not going to be changing because your spine is there.
Right.
It is what it is. And there are certain components, if you have sections above and below the fusion, our main goal will be to protection of that. So how you move, once something is fused, where's the mobility coming from when you bend forward? It's going to, or turn, or move. It's going to come from the segments above or below. And we, in Schroth, are going to specifically teach you how to protect that and how to move, including any residual, because remember, it's in the brain mapping, right? So if there's a way you've always moved your hip when you walk, it's not going to go away because you're fused, because that's your motor pattern. So we will also help we will evaluate the motor pattern and then help reteach the best way possible.
Right. That's great. That's a really great explanation. So moving to kind of different topic, there's a lot of people, there's a lot of marketing out there of, I've personally on my personal Instagram gotten a message that says, we can fix your scoliosis. What is your recommendation? For anyone who didn't hear, they both just sighed very, very heavily.
We have a lot of soapboxes.
So it's kind of two-faceted, my question. One, how do we make sure that someone who says they can do scoliosis-specific exercises is Schroth certified, knows what they're doing, isn't going to do more harm than good? And how do we deal with people and avoid those, I can fix your scoliosis situations?
Yeah.
Do you want me to take the schools, that question about certification, and then you get the other soapbox? First of all, Schroth is one of 7 scoliosis-specific exercises. So we kind of should have said that in the beginning a little bit, but Schroth is not the only. It is the largest in the United States, and the body that certifies, it's the Barcelona group. That's the largest in the United States. The institution, they have established, there's 5 main instructors, and they've established an institution. It's called Schroth Barcelona Institute. Okay, so that will have a list of certified therapists.
Exactly.
And it will also, so if you're looking for somebody in your area, you can go Schroth-BarcelonaInstitute.com, and it will have a list of PT directories based on where you live.
Right, and that's for the United States, or is that North America? Is Canada in there as well?
There are few other countries that are in there.
Right.
the ones that are trained by this group of 5 therapists, main instructors.
Right.
Let's say the website one more time.
Schroth-BarcelonaInstitute.com.
Right.
Okay?
Now,
Okay.
if you're international and you're looking for a Schroth certified therapist, you can go to the bspts.net. That's the Barcelona Scoliosis Physical Therapy School. So that is the main schools. Dr. Emmanuel Rigo, who trained the
5
original instructors in the original groups in the United States. So that bspts.net will provide you with an international list for those of our viewers that are outside of the United States.
Okay.
So from that, you have physical therapists. So this particular school trains physical therapists only. Not physical therapy assistants are not participating in this. That's key. Unfortunately, we've already started to see it in our area because this is growing, and there is a degree of marketing and you know, welcome to the United States, and
Right.
you can kind of sell something.
Yeah.
So I think some are trying to squeeze it into the general orthopedic physical therapy structure, and it is not. It is a square peg and a round hole. It's not hot pack east in modalities, exercise equipment. A physical therapy assistant shouldn't be participating in this. This is a constant, ongoing assessment and evaluation, which is the scope of PT solely for this. This is movement training. Now, that being said, the German school out of Shroff has trained more than just physical therapists. There are a number of chiropractors out there, and I can't speak to what their training consists of and how much. When we talk to parents that are looking at things like boot camps and things like that, I always tell them, you know, we are a profession and a field that is evidence-based, first and foremost. You know, being one of the first classes in the United States, we took this very seriously initially in those few years where the research was much smaller, and we were very clear with our parents and our patients about what we could and couldn't really expect. I think it's that due diligence and that understanding of the research that has elevated Shroff. We know so much more about it because it's been entrusted by this group of very dedicated physical therapists initially. And so be careful with other programs. First of all, there's no such thing as I can fix your scoliosis. If you hear that, run.
Again, no such thing as I can fix your scoliosis.
And certainly never bring it straight again.
Yeah.
I mean, we can all talk about the small curve and the very young, you know, who, you know, kind of settled into something under 10 degrees. Chintan had a case, and we still joke that she technically cured AIS.
joke about it.
We joke about it because her curve went under 10, and that's the criteria for diagnosis. But the reality is, scoliosis is a condition that actually impacts the shape of the bones and the discs and the soft tissue surrounding it.
Right.
It's not something that goes back. So when you have that condition, this is your spine. This is the condition that it is. Right. So run when someone says they can completely fix it. And but with regards to other programs, I begin to professionally become a little bit more concerned when you have so many variables that are not only very expensive, but multiple treatment approaches. You know, there's places that do neurotransmitter supplementations and these bizarre kind of long arm levered, and they weight a certain part of it, and vibration and chairs that they sit in for hours, which if you're in a chair that's pushing you passively for 4 hours, I'm not sure how that's different from a very good brace that allows you to walk around and do your life.
Like, just because something's pushing you for 4 hours doesn't mean the rest of the other 20 hours of the day you're
right.
going to be doing
So there's
that.
some fundamental mechanism of action validation of individual methodologies and treatment approaches that when you get into these, multivariable treatment approaches, I'm just more concerned. They just simply don't have as much of the evidence. It's not that, by any means that we are anti any other particular healthcare. We're really asking for the evidence, I have to say, Schroth practitioners and the physicians that have been involved in this, SOSORT has been a powerful medical society that has really pushed and driven for the research to show the efficacy of scoliosis-specific exercise and three-dimensional bracing. And so they've done the work, over a decade of hard work. I haven't seen in our history, in our fields, and I know that the Curvy Girls have actually played such a huge role. Let's be honest. Let's a little shout out here for our Curvy Girls. They've become a little powerhouse, haven't they? Because seriously, I'm not sure that the research would have gone that fast if there wasn't this grassroots push that said, we're seeing this growing body of anecdotal experience for this. People are flying all over and coming back and, jaws are dropping on things. What's going on here? Let's get some answers to these questions. And I think it's just a really exciting time period to see this come together like that. Such a powerful grassroots organization really starting to push and participate in driving the current questions and research for this particular condition across the board. I think it's awesome.
That's awesome, yeah. And I think it comes back to the fact that it puts so much more power and control back into the girls.
Yes. Absolutely. Absolutely.
I know we've been talking for a while. I'm going to see if I had any other comments on other posts, because I know we posted in a few spots. All right, so we've been talking for almost an hour. I told you guys this was going to go super fast. Like, all of a sudden, an hour is done. So I actually have an idea. So I think we should do a part 2 eventually. Maybe next month, in a few months, or something like that. And I think it'd be really cool to... I'm sorry, I'm totally putting you guys on the spot. They have no idea what I was going to say. I think it'd be really awesome to get a Schroth patient, a Curvy Girl in, and we could do a live stream and talk about some of the exercises that she's doing, show her x-ray, and kind of talk about, show everything that we just talked about.
Sure. I think that's completely doable.
Cool.
We've got a number of girls that would jump at the opportunity.
Yes,
I'm sure.
And I know Rachel is only one of them.
Well, now Rachel's not fair. Like I said, she's like the Olympic level of it.
Right. And we're talking about the vice president of Curvy Girls
yes,
here.
We are.
She is the whole reason that I know about Shroff even.
Yes.
Okay, so to kind of wrap it up, do either of you have parting words, any last thought you had, question I didn't cover that you really wish I did?
I always like to say to parents that are wondering if this has value for their teen who is very defiant and not doing it, and I say yes, because the educational piece will go with them, and you don't know what that young teenager who's going through a challenging time is going to come around to when they're in their 20s.
Right.
And again, our fastest growing population are women in their 50s who wish they had known some of these things. They were chasing a shoulder or a neck or a hip or a knee pain, and no one had any idea it had to do with their biomechanics and their spine.
Right.
So I encourage, parents to continue this team approach. I think if you find a good team, not just the therapist and the physicians and the ancillary staff and the Curvy Girls, I think there's a better chance of having some of this education stick, even if perhaps the compliance weans off a bit.
Right.
And at least in our facility, they take an entire binder home with them for life,
Yeah.
And as long as they don't burn it, we're good.
But I think, as long as you're doing, if you're taught, 100 things and you do 50% of it, it's better than doing none of it.
Yes. Better than the 0%.
Better than 0%.
And we haven't even encroached upon the question of the neuromuscular re-education.
Right.
If we've done a successful job of changing some of the motor patterns, that child leaves with a changed motor pattern that they don't need to think about anymore.
Right.
So it's an interesting question. We're far away from that level of research, but hopefully moving forward.
We and just to kind of piggyback on that, we've actually had patients that come back and are supporting our teaching of the younger PTs and things like that.
That's awesome.
And we tell them, don't stand in your corrections, don't do. And they're not able to go back to where they were originally. They're
that's
like,
funny.
This is how I stand, Miss Chen. I don't know how to stand. So there is something to be said about what that motor learning is. Again, research will really, and we need time for that because these are the long-term studies that will show us of how much of that residual effect is kind of staying. But I think it's an exciting time. I think during the very tough ages, like you said, Schroth, I think just empowers them. It is not wait and watch. It's really try and see. It gives them a tool that they can get a handle on this for themselves.
That's awesome. Very cool.
And thank you guys for always being the support and the backbone, the backbone of these young girls, because I think it's at a time when they need it the most.
Critical.
Definitely. So I think let's close it off by just saying one more time where everyone can find Schroth resources, the website. So.
Sure. So in the United States, if you're looking for a Schroth certified physical therapist, you go to Schroth-BarcelonaInstitute.com. That should give you a list of the certified therapists.
So if somebody
there are C1 and C2 level therapists. Again, C1 is for your typical adolescent idiopathic scoliosis. C2 is for any of the advanced applications. Younger age, early onset or juvenile, post-fusion, if you have painful degenerative aging scoliosis, that is C2 level. For the international...
Sorry, I'm going to just cut in. If someone says, I do Schroth, and they are not on that list...
I would then ask, where did you get your certification from? How long was that training? How many years have you been doing it? Again, we know that we know that there are other schools and that they potentially train other healthcare professions. But one thing I can't stress enough is physical therapy. By its definition, we are the healthcare licensed professionals for the science of movement. Right. So when you're talking about teaching movement that is specific to a condition such as scoliosis, I kind of think it really is very appropriate that physical therapy is the profession to do that. There is a tremendous amount involved in motor training and motor control and motor learning, and that's really our field.
That's awesome.
It's doctoral level now.
Yeah. That's true.
Yes.
And then the international website that I cut you off from saying.
Yes, the international website is bspts.net. So that is the Barcelona Scoliosis Physical Therapy School.
Awesome. Great. Thank you guys so much
for coming. Thank you so much for coming.
And thank everyone who tuned in. This video will be posted on our Facebook as soon as we are done with this. If you missed the beginning of it, if you missed the middle of it, and if you have any more questions, you can actually still comment below, and you guys could answer it from your Facebook page.
Yes.
Absolutely.
Those of you from the parent Facebook page may recognize my name.
Yes.
So we'll do our best to answer. I see a list of questions that we probably didn't get to, so I'll do my best to hit that up.
Yes. All right, everyone. Have a great evening, great morning, wherever it is that you are in the world. Bye.